Everybody ready? Okay. Well, good afternoon, everyone. This morning we held a very interesting hearing. We had a variety of panelists talking to us about what this committee should be doing by way of strengthening programs within the jurisdiction of this subcommittee to prepare for what I believe to be the reality that the next president is going to have no choice but to deal with the issue of universal health coverage. And it would be kind of nice if we were ready for that, and it would be kind of nice if we were spending money on things that actually worked, especially since a lot of that money is going to be the taxpayers. We also talked about the fact that so often in appropriation hearings, we talk in dollar terms rather than human terms. And when we do talk in dollar terms, we usually talk in terms of what it costs to do A, B, or C, or D in any given field. But what we also need to do is to balance that off by asking what does it cost us not to do certain things. And so that's what I would hope our witnesses could focus on and remind us of today. We have, for instance, Doctor, when we had the meeting in the Speaker's office earlier this year, I used the example of Lou Gehrig's disease. We know that the country spends a little over $40 million, it's been estimated, to try to understand that disease. But we have, 30,000 people who are afflicted with that disease, and it costs us many times that amount in lost wages, in medical treatment, et cetera, et cetera. So I think we would be more inclined to invest more money in some of these research efforts, in some of the public health efforts, and a number of other areas, if we gave as much attention to what it costs us not to proceed as it does to proceed. I think my attitude toward the administration's health care budget this year is well known. I have minimum high regard for it, to put it politely. But nonetheless, the budget is here. The administration has submitted a budget that freezes all funding for biomedical science, spends $475 million less than last year on critical public health promotion and disease prevention programs at CDC, cuts funding for health care outcomes and effectiveness research below last year's level, and cuts funding for substance abuse and mental health treatment and prevention activities. I think we need to face squarely what these programs cost us, but I also think we need to face squarely what the consequence of inadequate attention to these problems winds up being for the country. And that's what I hope we can cover today. So I'll be happy to call upon the witnesses for whatever comments they want to make after I've asked Mr. Walsh for whatever comments he might have.
Mr. Chairman, we have a lot of witnesses before us. I think I'll just allow them to go ahead and proceed, and hopefully have some questions afterward. But thank you for holding this hearing, and we welcome the witnesses.
All right. We have with us today Dr. Elias Zerhouni, Director of the National Institutes of Health, Dr. Julie Gerberding, Director, Center for Disease Control and Prevention, Dr. Terry Klein, Administrator, Substance Abuse and Mental Health Services Administration, and Dr. Carolyn Clancy, Director of the Agency for Healthcare Research and Quality. Dr. Zerhouni, why don't we begin with you? Did you bring your musical instrument?
Thank you, Mr. Chairman.
You're not going to answer that question?
I'm sorry.
You didn't bring it?
I was trying to avoid answering it because I think that instrument would be the focus of attention instead of the NIH.
That wouldn't be.
But I thought it was a great opportunity for us to come in front of you and members of the committee to explain I think, what the overall strategy of the NIH is, and really focus my comments on the highlights of the testimony we've submitted for the record, but to try to just identify the four essential points that I think need to be understood to see where I think medicine and discovery and healthcare need to go over the next few years. The first point I'd like to make is that the investment of the American people at the NIH has paid dividends that are difficult to overstate. The reduction in mortality of heart disease alone by 70% and stroke by 70% has allowed an economic return that is much greater than the spending that we incurred in terms of researching heart disease. I think we've made progress on many fronts to the point where acute diseases that were short-term and lethal in the past are no longer the main challenge. The main challenge has become chronic diseases, and chronic diseases represent 75% of our expenditures. And it's clear that this rise of costs in healthcare is, I don't think, sustainable, and no one today believes that there is a straightforward strategy to sustain these costs over time. And no one believes that what we've done in the past and the strategies we've followed in the past are going to be effective in the future. As Einstein said, a bad scientist is a scientist who keeps trying the same thing, hoping for different results. And we have to change our strategies. The challenge in front of us, obviously, is that we have had in the past a certain paradigm of healthcare, which was to strike the disease once it had struck the patient, waiting for the disease to really appear before we did anything. The sort of late reactive episodic type of care is no longer what will be needed in the future to manage chronic diseases. We will have to be more proactive, and this is what we call the new era, whereby the research that we do needs to enable us to understand disease at its beginning, before it strikes the patient. And to do that, we call this the 4 Ps of modern medicine. We need to be more predictive. We need to find the markers, whether it be genetic markers or other markers, that identify the risk of an individual. We need to understand the environment. We need to understand how to prevent. And in many cases, we may not be able to do that, but we need to continue the effort to find ways of delaying the onset of the disease or reducing its complications, and continue to do the research that we need to do to alleviate the suffering of millions of patients who currently suffer from these diseases. So the landscape of disease has changed. Our strategies have to change. And those strategies have to be a lot more proactive, more prospective than they have been in the past, which means that for the NIH, we have to continue to do the research we do today, but also expand into new areas of science. Areas of science that will allow us to understand not just at the atomic level or molecular level, but also at the cellular level, at the tissue level, at the organ level, at the mind and body level, all of the components that lead one from a healthy life, healthy status, to an unhealthy status. And therefore, the scope of our research has grown. Last but not least, I would like to say that life sciences are going to be the critical challenge of this century for any nation, just like physical sciences were in the past century. Those who develop the knowledge to overcome the challenge of rising healthcare costs and find a way of not just improving how they deliver care, but what care is being delivered, are going to be the nations that will sustain their competitiveness. And that will require a focus, which is my last point, on the next generation of scientists. Nothing keeps me awake at night more than the fate of early career scientists who get discouraged from entering science at a time when the nation needs more scientists, more engineers from all walks of science to be able to meet those challenges. And our budget reflects these priorities. We try to maintain the number of investigator-initiated grants. We try to create programs that encourage early career scientists to remain in science to the greatest extent possible. So those are the comments I wanted to make to highlight the priorities that the agency has at this point, and I'll relinquish the rest of my time for questions.
All right. Dr. Gerberding.
Thank you. Is this functional?
No.
Try this. Thank you very much. It's a real honor to be here and to have a chance to appear with my colleagues. I'm sure I'm going to learn a lot more from this hearing than I will contribute, and I'm very grateful for that. I'd like to pick up where Dr. Zerhouni left off and talk a little bit about how health happens. There are three questions that plague us at CDC. One is, why, if we're the nation that spends the most on health, aren't we the healthiest nation? We're actually 37th in the world, according to the WHO. Why might our children have shorter lifespans than their parents? And fundamentally, why is obesity becoming a national security concern in the United States? And I think those are all three reflections on the fact that we just simply do not have the value in our health system that we need. And part of that has to do with, again, fundamentally rethinking about how health happens. So if I can have my slides, I wanted to start with the traditional health care delivery system, starting with the discovery phase at the NIH and CDC and elsewhere, moving to patients through translation, bench to bedside, then translation into evidence-based practice guidelines, something my colleague Dr. Clancy knows a lot about, and from there really being translated into widespread clinical practice so that everybody can benefit, and finally, we hope, the fourth level of translation into achieving the kinds of true health outcomes and benefits to all people. The problem in our country right now is that this last element is particularly blocked. People are worried about access and cost and care, and it doesn't matter if you read the New England Journal whether they're Republicans or Democrats. This is a major concern for people everywhere, and we know that we've got major problems in these areas. But even if we alleviated these problems, we would still not necessarily have the health that we want, because the health in our country has more to do with things that happen outside of the doctor's office than it does with things that happen inside of the doctor's office. And that's where the public health system comes in, and that's why the investments that we make there are so very, very important. So we think that there is a comparable highway to health that's not one that is receiving the attention that it deserves, but one that is equally, if not more important, in getting us as a healthy nation. Starts again with research that gets translated to people in communities and schools and the workplace. From there, we develop public health practice guidelines, evidence-based practices, the things we know work. And then we need to translate those into widespread uptake so that health departments and communities everywhere can benefit from them. And finally, then, we see that health, as we measure it in a holistic way in our society, ultimately will be achieved. Both of these highways have to be functional, and investments in both of these areas contribute to people's health, and I think ultimately to our ability to be one of the healthiest nations in the world, a status that we do not currently enjoy. There are lots of things that we know work and lots of things we can talk about scaling up, ways we can put health in policies beyond the policies in this committee, health in agriculture, health in transportation policies, health in commerce policies. But I think there's also a very important need to market what we know works and to get it diffused and disseminated and taken up widely using some of the new technologies that we have at our disposal today so that people everywhere can benefit.
Dr. Klein.
Mr. Chairman, members of the subcommittee, thank you very much for the opportunity to be here today. I'd like to request that my written testimony be submitted for the record. During my tenure as the SAMHSA administrator, I have had the benefit of traveling across the country and seeing the amazing results of some SAMHSA-funded work. I have seen men and women reunited with their children after conquering addiction. I have seen people who are managing their mental illnesses and getting jobs and reclaiming their lives and becoming contributing members of our society. As SAMHSA, helping more people have that opportunity to achieve these same results is a focus of our work. So we've also been working to move upstream to prevent many of these conditions from occurring in the first place by emphasizing the public health approach to well-being, and I think this is a theme that you'll see throughout the afternoon. I learned the value of taking that public health approach as a freshly minted psychologist on the streets of Cambridge and Somerville and Boston, Massachusetts. My first professional job was providing home-based therapy to families who are living in low-income housing developments in those areas. So as I walked to my appointments every day, I would walk by many other families who I knew needed help as much as the family I was going to see. So, but I simply didn't have the time to work with the other families, simply did not have that opportunity to work with them. I was only able to offer that therapy one family at a time. So walking by 15 families that I knew were in need to reach that one family just didn't seem like the right thing to do. It certainly wasn't right to do that then. It's not right to do that today. Something significant needs to change. I remember thinking that there had to be a better way to deliver services. There had to be a better way to reach more people in need of mental health and substance abuse services in our country. I thought of the opportunities with those families to intervene earlier. I thought of those opportunities to actually prevent many of the problems that they were experiencing from occurring at all. That experience is why I believe so strongly that we need to adopt a public health approach in our overall work that we do. So the public health approach really involves us moving upstream as well as involved in the work that we're doing downstream. So while we continue to rescue those drowning individuals, we also need to move upstream and prevent and keep individuals from falling in the river in the first place. So the public health approach, as you know, recognizes that behavioral health is inextricably linked to overall health, and the integration of these is valuable and necessary. That's why I'm so passionately convinced that mental illness and substance use disorders should be and must be treated with the same urgency as other health conditions. So one way to accomplish this goal of service integration is to strengthen the relationship with primary care providers. Primary care practitioners have access to a much larger segment of the population than we see in the specialty services. We need to take behavioral health services to the people where they are and not wait until people are in crisis. By encouraging healthcare professionals to identify at-risk populations and to intervene early in their lives, we can significantly reduce the burden of substance abuse and mental illness among Americans and our social institutions. There are several models of primary health care and behavioral health care integration. One particularly useful model focuses on behavioral health screening through primary care. So I'd like to talk just briefly about that. For example, through one grant program that focuses on substance abuse, SAMHSA is implementing screening, brief intervention, referral, and treatment services in trauma centers, emergency rooms, community clinics, federally qualified health centers, and school clinics. These programs provide screening strategies for intervention before the individual needs those more extensive or more specialized services. So far, our grantees have screened over 545,465 individuals across our country. Of those screened, 22.9% of those individuals screened required a brief intervention, brief treatment, or a referral to a specialty treatment. At 6 months post-intake, 74% of those individuals reported lowering their drug or alcohol consumption after one or more brief interventions. So of those individuals, 48% reported no substance use at all. Through technology training, we must continue to keep working to bring new knowledge treatments, preventive strategies developed by our research institutes to daily community-based practice. We have never, ever before known so much about the prevention and treatment of mental illness and substance use disorders. Now we need to actually do what we know. Mr. Chairman, members of the subcommittee, I'm optimistic. I look forward to the day when mental illness and substance use is treated with the same urgency as other illnesses. I look forward to the day when a public health model ensures that preventing illness is as much a priority as treating illnesses in this country. And I look forward to the day when we have policies and systems in place that will build resilience and facilitate recovery. Then and only then will we have a truly rich and healthy nation. I'd like to thank you for the opportunity to be here today, and I look forward to answering any questions you may have. Thank you.
Thank you. We are halfway into a vote on the House floor, so I think we had best recess at this point, go over and vote, and then come right back, and we'll then hear from Dr. Clancy.
Is that on or off?
Check one, check one. Can you hear this? Check, 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 check.
Testing, testing.